In this video, we're going to talk about understanding EKGs and helping you to better understand how it works. So that way you'll be able to interpret it when it comes to your nursing exams or heart rhythms. Whatever you need this information for, you're going to find this beneficial. So definitely watch this video all the way from the beginning to the end. Okay, so my name is Nurse Chioma, and I have been invited by Picmonic to go over this topic with you today about EKG interpretation. So let's go right into the topic, and you'll definitely want to also watch a different video that I also did, which is all about the cardiac system, because it will give a really good foundation into what we're talking about today. So here's the thing when it comes to better understanding EKGs and EKG interpretation is that first you got to know the basics, right? And so once you understand the basics, then everything else becomes easier. And one thing I always say is that you want to do things in increments or kind of like stages. And what I mean by this is that for many people, when they're trying to learn something, they try to learn as much as possible simultaneously, right? And so when they do that, it can seem like really overwhelming and just honestly hard to understand. But if you break it into bite sizes, then you're going to see that it's not as hard or as difficult as you think it may be. So the first thing, number one, is that you got to first learn the electrical conduction system. So the electrical conduction, because the electrical conduction system, that is pretty much the system that will help you to understand the purpose behind EKG strips. It will help you to understand how to interpret it. And it will just honestly help you understand the basic role of it. And so that's going to just make a world of a difference so that way you can really know how to interpret EKGs, okay? So here's the first thing is talk about the electrical conduction system. This is the foundation. So if we was to look at a heart, right? So let's say you're looking at a heart right now. One thing I talked about in the cardiac video is that the reason why people struggle with EKGs is that, or the cardiac system, is that you're not aware that there's different types of processes, or one reason, processes, things that's going on simultaneously in the heart. And so when we look at the electrical conduction system, first we want to focus on some very important parts of the heart that's not easily seen with the naked eye. So first we have the SA node, right? So the SA node is located right on top of the atrium, okay? Especially on the right side. So that's where the SA node is located. And I usually like to say that the SA node is our heart's natural pacemaker, all right? So the SA node, this is the way that the rhythm starts, all right? The SA node is pretty much where the rhythm starts. And what you want to kind of see it as is that when you're looking at an EKG strip, you're literally watching and seeing a reflection of the movement of an impulse that starts from the SA node all the way through the heart. That's literally what you're seeing, is that you're literally seeing the movement of that impulse. And so the better you understand the anatomy of the heart, the better you understand the different parts of the heart that plays into this system, the easier and the more obvious it's going to be when you are learning EKGs. So first we have the impulse, the SA node will fire an impulse, and that impulse will travel down the atrium, okay? So when it travels down the atrium, then what will happen is that the atrium will contract. And when it contracts, that's what we call atrial depolarization. All right, so step one is that the SA node will fire, release that impulse. Impulse will travel down the atrium will contract, bam, that's atrial depolarization. And that reflects the P wave on the heart, on the rhythm, okay? So that's the P wave. Then after you see the P wave, then now like I said, the atrium contracts, right? So when that impulse hits the AV node, That's now the PR interval, all right? Because now that impulse has hit the AV node. So that entire sequence or that entire organ or system, as far as the SA node traveling down the atrium contracting, atrial depolarization, the impulse hitting the AV node is the entire P wave and also PR interval. Then the AV node is going to fire now. So the AV node is located on top of the ventricles in the heart. So the AV node is going to also release its impulse too. And when it releases that impulse, the impulse is going to travel down the bundle of His, and it's going to go, and the bundle of His is pretty much like, I would say it's that space between the left and the right ventricle. So it's going to travel down that space, or that kind of like a canal, right? And then it's going to be released through the Purkinje fibers, which is located in both the right and the left ventricles, right? So here's what happens, right? So that, like I said, the impulse is going to hit the AV node. The AV node is going to also release that impulse, right? Release that impulse. And that impulse is going to travel down the bundle of His, travel through the Purkinje fibers and through the ventricles. And now the ventricles are going to also contract, right? So now the ventricles will contract. And now that the ventricles have contracted, that's what we call ventricular depolarization, right? So now, so that whole sequence from the time that the impulse leaves the AV node all the way down the bundle of His, then the Purkinje fibers throughout the ventricles, and the ventricles contracting is ventricular depolarization, okay? Then now that now that would reflect on the rhythm, the QRS segment, okay? So that's the QRS segment now that you're looking at it on the rhythm, all right? Then now what will begin to happen? Now the heart will begin to relax. So the heart will begin to relax, it will begin to refill, and it will get ready to do the process all over again. So as it's relaxing and it's refilling, that's now what we call ventricular repolarization, right? So pretty much during this time, the ventricles are relaxing and it's refilling up to get ready to do the whole process all over again, and the SA node to fire all over again. And so right to that, up until that point, that's the T wave on the rhythm, all right? So that comprises the P wave, the PR interval, the QRS, and the T wave. So you see that? You see how literally that's what you're looking at? You're looking at the movement of an impulse that's traveling through the heart, right? And so this is one of the things, is that once you understand that, then you'll see how things kind of differ when we have patients that have different types of heart problems and different types of just changes in their anatomical structure, especially if they have ventricular hypertrophy, right? So that's when their ventricles are bigger than it's supposed to be. Ventricles are dilated than it's supposed to be, right? Like in heart failure. And a lot of times we're going to see something called bundle branch block. Bundle branch block, now this is where now that QRS, right, segment is wider than it's supposed to be. Because why? The ventricles are bigger, right? So that time that the impulse takes to travel through the heart, travel through the ventricles, it's taking longer. And that's what results in that QRS segment being wider. You see that? So that's just kind of explaining right there, breaking down, first and foremost, like I said, all the P wave, PR interval, QRS, and the T wave, right? So I hope so far that this is making hopefully more sense to you, and hopefully you're getting a lot more clarity. Because if you feel like you're overwhelmed with the EKGs, you really honestly have to just take it in steps. And once you begin to take it in steps, oh my goodness, you're going to see a world of a difference. If you're liking this video so far, make sure that you go ahead and like the video, share this video, comment below as well. Let us know that you're tuning in, that you're watching, that you're following along in the comments, so we can engage from you and we can hear from you as we move along this video. And I want to share something before I even forget. This is one of the shirts that Picmonic recently gave to me here. If you see that here, Okay, so it says Nurse Like a Boss from Picmonic. There's some really great gear, some really great different things that they sent, and it's really awesome. I really enjoy their gear. So if you want to check it out, it's really, really comfortable. They have so many different types of shirts, so many different types of gear that you'll absolutely love and adore. Okay, all right, so now let's keep going, okay? So that's all about the electrical conduction system, which pretty much, what did we just describe? We described normal sinus rhythm, right? That's pretty much what we just described right now, a normal sinus rhythm. So now hopefully will this help you to better understand is now the different types of rhythms as well as the abnormal rhythms. So when we look at, for example, if we look at the first step, so what I do is I typically will say, okay, the first step is understanding the electrical conduction system, right? That's step one. Once you understand that system, which we just explained, then that plays a role with understanding sinus rhythms, which includes normal sinus rhythm, right? And then sinus bradycardia. So sinus bradycardia, sinus tachycardia, and sinus arrhythmia. Those are some of the sinus rhythms. Then after the sinus rhythms, then I would say you want to then learn atrial rhythms. Okay, so atrial rhythms are pretty much abnormal rhythms that involve the atrium, right? The top half of the heart. Then after that, then I would actually encourage you to learn about junctional rhythms. So I'm just kind of giving you the steps to learning the rhythms, the different rhythms, so that way it makes more sense. So a lot of times for many people, the reason why things don't make sense or you're forgetting it is because you're learning it in the wrong order, right? You're either learning in the wrong order or you're not creating an order for yourself. And so think about nursing school, or if you're in medical school or you're a PA, whatever your background looks like, there's a reason why they take you through certain fundamentals before they expose you to more difficult topics, because it's going to play a role with you understanding the next part. So now when we look at, like I said, the next part would be junctional rhythms, right? So junctional rhythms is now when there's an abnormality where the P wave is not even showing on the rhythm. Then after that, then I would tell you to learn ventricular rhythms, which is an abnormality with the ventricles, right? So the ventricles aren't really working the way it's supposed to. And then finally after that, then you want to also learn heart blocks. So there's different types of heart blocks. And then another thing too as well would be to learn some of the extra rhythms or the extra beats, such as PACs or PVCs. Those are also really important to know too. So if you kind of break up the steps in that order, you'll see that EKG is not really as hard as you think that it is. All right, so let's kind of go over maybe just like one of each component, just to kind of give you some better clarity and understanding. All right, so let's go over like one of each component. So sinus bradycardia, right? So sinus bradycardia is a type of sinus rhythm. So when it's this, what it means by saying that a rhythm is a sinus rhythm, it means that it has all of the components of the rhythm, okay? Has all the components of the rhythm. It means that the R to R is regular, which makes it a regular rhythm, typically. And then also it has all the components, and each of those components are in the normal range, right? As far as the length of the PR interval, the length of the QRS interval, and et cetera. Okay, so now the difference though when you have sinus bradycardia is that this is the number of beats in, for example, a 10-second strip. So the number of beats is too slow, right? It's too little. So the normal number of beats should be 60 to 100 beats per minute. But when somebody has sinus bradycardia, those beats are moving too slow. So instead, it's going to be below 60 beats per minute. So what makes somebody have sinus bradycardia is simply the fact that the number of beats per minute is too little. It's under 60 to be exact. All right. So here's a couple of things that you need to know, and you should know this as well for all the abnormal rhythms. You got to know why somebody would likely have that abnormal rhythm, right? So why would somebody have sinus bradycardia? And then you should also know what it looks like if they're symptomatic, right? What it means if they're symptomatic. And then how you would treat it, right? Those are some of the different things you should know. You should also, of course, know the risk factors, right? So if we're looking at sinus bradycardia, one thing we will say about sinus bradycardia is that you can have somebody that has sinus bradycardia, but they're fine, right? So meaning that they're asymptomatic. So they don't require any form of treatment. They live like that. That's just how they are, and they're actually healthy. So we see this a lot in athletes, right? Individuals that are athletic, sometimes also teens as well, because they tend to be more athletic, younger, which is good, all right? So as long as they're not symptomatic, they're fine. But if you have a patient that has sinus bradycardia, but it's not normal for them, they're not an athlete, and they're symptomatic, then there's a problem. And they could be symptomatic in the sense that they have shortness of breath. You can notice a change in the color of their skin, right? There's different types of symptoms that you can see in the patient because they're symptomatic. So because they're symptomatic, you're going to need to treat them. So they're going to need medications typically to increase the heart rate. But the best treatment you can give them is the underlying factor, right? That's the best treatment you can give them. So if we can identify what's causing this abnormal occurrence of sinus bradycardia, then by all means, that would be the best treatment, right? So for example, let's say there's a medication that they recently started on, the doctor started them on recently for whatever the problem is. And so that medicine has a side effect of bradycardia, and that medicine is causing it. Then that would be the clear, obvious answer would be to stop giving them that medication, right? As well as also increase the heart rate. And we can typically increase it by giving them drugs such as atropine. Atropine is one of the most common medications that we're going to give to the patient. So that would be sinus bradycardia. Then another one I also forgot to mention too with the sinus rhythms is SVT, supraventricular tachycardia. So you have sinus tachycardia, which is greater than 100 beats per minute, but it's usually 100 to 150 beats per minute. And then you have SVT, which is more than 150 beats per minute. Oh my gosh, that's super, super fast. All right. So SVT is something that is critical. It's an emergency, a medical emergency. You have to respond to it right away. You need to do something. So when you're looking at each of these rhythms, you should know as well, is this a medical emergency? Is this a medical emergency? And if it is, what do we typically do? Because if it's a medical emergency and you don't respond right away and you don't know what to do to respond right away, you could put the patient at risk, right? So here's a good example of this. Atrial fibrillation. Is atrial fibrillation a medical emergency? What do you think? Let me know right in the comments, actually, even before I tell you the answer. Let's make this engaging. Is atrial fibrillation, and we'll know by what you put in the comments, is this considered a new onset atrial fibrillation? Is that a medical emergency? Here's the answer. You ready for the answer? Well, it honestly depends, but typically it's not. All right. So here's what I mean by this. So atrial fibrillation, it usually becomes a chronic problem. Okay. So a lot of times when you see a patient that comes in with atrial fibrillation and it's new onset, right, meaning it's a new diagnosis, they never had it before, then usually their history may include heart failure, heart disease, heart attack, different types of heart problems, stroke, diabetes, different illness that they may have had leading up into this point. So atrial fibrillation is going to cause the patient most of the time to experience some type of symptom. And the number one symptom, chest pain or even palpitations. So the thing about atrial fibrillation, it's not a medical emergency, but we need to do something though. We need to treat the patient. And typically what we like to do is that we want to respond right away or as soon as possible. And we can try to correct the rhythm, but a lot of patients honestly end up living with atrial fibrillation. So we may do cardioablation, cardioversion, we may give them amiodarone, just different type of medications. They are going to need to be on Coumadin, because the reason why is that when they have atrial fibrillation, their heart is erratic, the atrium is erratic, it's not beating normally. And as a result, oh my goodness, there's a higher risk of them having a stroke. So the Coumadin is just to prevent the stroke from occurring or them from getting a blood clot. It doesn't actually fix the rhythm, okay? So with atrial fibrillation, we want to respond right away, we want to respond as soon as possible. Typically, they tend to, their heart rate, if their heart rate is under 100 beats per minute, it's called controlled atrial fibrillation. But if it's above 100 beats per minute, it's uncontrolled. And if it's that fast and it's AFib, and they're symptomatic, then that's an emergency. Because at that point, if the heart keeps beating that fast, they're going to go into cardiac arrest, right? In addition to the increased risk for blood clots, stroke, etc., right? So I know kind of tricky question as far as if it's medical emergency, but it really depends on different factors. Now, atrial flutter, though, is different. So a lot of times, especially when I'm working with some of my students, they struggle to recognize the difference between atrial fibrillation versus atrial flutter. And one thing you want to understand is that they look very different if you really look closely at the rhythm. Now, inside the Picmonic portal, they have so many different videos and trainings and teachings that will really highlight this so you can understand it from a more visual perspective. But when we look at atrial fibrillation, the lines, right, when we look at the P wave, right, so now that we know what the P wave is, the P wave, it's like to me, I would say, it's not uniform as far as the P wave. There's multiple P waves. It's like a squiggly type of it's not uniform. But with atrial flutter, they usually will describe it as sawtooth, all right? They're sawtooth and they're usually uniform. And the patient will often describe saying that they feel like there's a fluttering in their chest and they're complaining of palpitations, right? That's often that they'll describe. So atrial flutter is an emergency. Atrial flutter should be treated right away. There's no such thing as a patient having chronic atrial flutter. It needs to be treated immediately, and we need to do something right away. Now, the treatment for atrial flutter is the same, actually, for atrial fibrillation. So we will do the same thing, cardioversion, cardioablation, and usually it is corrected after we do that. There may be some patients that may interchange between atrial flutter and atrial fibrillation, but the main thing you need to realize is that atrial flutter is something that needs to be treated immediately. It is not something that they live with. It's not a chronic issue. Sometimes it become a chronic issue. It's atrial fibrillation that becomes chronic and is not usually cured even after treatment. It's just managed, okay? So oh my goodness, we talked so much already as far as we talked about SVT briefly, sinus rhythms, and then we also went over the difference between atrial fibrillation and atrial flutter. Right? So I would really implore you to pay close attention to the differences. So because one thing I tell people often that when I'm trying to teach them and help them to understand, they will often assume, or they will often find themselves like reading and studying, but like what something is, but they won't pay attention to what makes this different from this. Right? So right now, we just talked about the difference between atrial fibrillation versus atrial flutter. That's the thing that you need to be aware of, is that you want to pay attention to what makes something different just as much as what something is, because it will play a huge role with your ability to better understand what it means and what it looks like. Okay, so then another thing is understanding, ventricular rhythms, right? So especially with our VTach and V Fib. And another one that I didn't mention as well is Torsades de Pointes, which is like a really weird, super jagged rhythm. It's not controlled at all, and typically it's because they have low magnesium levels. So we usually treat it by just giving them magnesium. But when we have the ventricular rhythms like VTach and V Fib, those are also considered emergencies. And those need to be treated right away. They have slightly differences as far as how we treat them, but for the most part, we defibrillate and we need to start CPR right away. When you see a VTach or V Fib, this is an emergency. This is literally, in the matter of minutes, okay? So minutes, seconds, that the patient could die if we don't do something immediately. That's how emergent VTach and V Fib is. And we oftentimes see it with those patients that have a lot of chronic heart problems, chronic heart conditions over time, and their heart just pretty much gets worse and worse over time. We may also see it with patients who have a previous medical history of other chronic issues, but then also patients that have used a lot of illicit drugs too, such as methamphetamine, heroin, cocaine, chronically, because what those drugs do, those illicit drugs, is that they overwork the heart. And over time, if the heart is overworked, the heart will begin to fail and the ejection fraction will go down. Okay, so a lot of times patients that have a history of illicit drug abuse, they are the ones that need open heart surgery. They need a heart transplant. I've seen people literally in their 20s, 30s that need to have their heart, they need transplant. They need to have stents placed and et cetera. Kind of crazy, right? So this is some of the things that you want to really better understand when it comes to EKG strips and EKG interpretation is first kind of breaking it down like the way I would highly recommend you to really listen to this thoroughly over and over again with each of the steps and each of the principles that I laid out, because it's going to make a world of a difference to helping you to better understand EKGs. Now, like I mentioned before, if you check out the Picmonic portal, they have a wealth of resources and libraries that will help you to better understand EKGs visually as well as the cardiac system. So I hope that you found this video informative. If you did, please go ahead and like this video, thumbs up, share the video right now with somebody that would benefit from this teaching. I definitely appreciate you for watching it. Once again, this is Nurse Chioma, founder of Choosing Nursing. Thank you so much for watching the video. Thank you for subscribing to the Picmonic channel, and we'll see you the next time.